This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa New Zealand and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa New Zealand.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest clinical guidelines and research in obstetrics and gynecology through conversations with leading experts. Today, we are discussing the Australasian Diabetes and Pregnancy Society, ADIPS, 2025 Consensus Recommendations for the Screening, Diagnosis and Classification of Gestational Diabetes, which was published in June 2025. With nearly 1 in 5 pregnancies affected by GDM, it's one of the most common complications of pregnancy. Treatment is found to significantly reduce the risk of adverse pregnancy outcomes, and patients with GDM are at least 7 times more likely to develop type 2 diabetes later in life. The ADIPS guidelines were last updated in 2014, and the 2025 recommendations come after a thorough review of the latest evidence and extensive consultation with health professionals and patients with lived experience. For the first time, key relevant peak bodies representing GPs, obstetricians, midwives, diabetes clinicians, and pathologists have united in support of the recommendations. Please note that these guidelines are relevant for Australian practitioners, with separate guidelines under development for Aotearoa New Zealand, which will be covered in a future episode. I'm your host, Dr Nisha Khot. I'm an obstetrician and gynecologist based in Melbourne, and I'm the president of RANZCOG. Joining me for this discussion today is Associate Professor Alexis Shub. Alexis, let's hear a bit more about you.
Hi, Nisha. I'm a maternal fetal medicine subspecialist at the Mercy Hospital for Women and lead of the diabetes clinic there. I'm also a board member of ADIPS and was one of the authors of these consensus guidelines, so that's my conflict of interest.
Thanks very much. To start us off, Alexis, could you please run us through the key changes in the new ADIPS guidelines?
I think the things that are really much clearer now compared to our previous versions is we're very clear about how to go about early pregnancy screening, who should be screened, and part of that results in less women needing a second or 2 GTTs in pregnancy. So that's an enormous bonus for all of those women. We're relying much more on early screening for type 2 diabetes with a hemoglobin A1C, so a single non-fasted blood test, again, much more convenient, less blood tests, less time for women. And importantly, we've changed the diagnostic thresholds to diagnose GDM. So those thresholds have gone up, and that means that less women are being diagnosed with GDM. We do still really importantly recommend that all pregnant women who haven't already got a diagnosis of diabetes of some kind are screened at 24 to 28 weeks with an OGTT. So that hasn't changed. That's the same.
That's really great to hear. Tell us what the reasons are for these changes.
So I think we've got lots of really fantastic data in the last couple of years suggesting that that very mild hypoglycemia isn't really associated with significant adverse pregnancy outcomes. So using a higher glucose threshold lets us concentrate on the women and pregnancies and babies that have the most to gain from having treatment of gestational diabetes. And that reduces unnecessary burden on patients and on health services.
Could you also explain what benefits this might carry for clinicians and for patients?
Yes, so the reduction in the number of women diagnosed with gestational diabetes means that care is really focused. Looking after gestational diabetes is a burden for the woman and for clinicians, and so now we can concentrate all of that input, diabetes nurse educators, dietitians, obstetricians, midwives, endocrinologists, on the women who have the most to gain. So it's a sensible use of our resources. And using the hemoglobin A1C test in early pregnancy means that less women have to have a GTT in early pregnancy, and that can be a pretty unpleasant test when you're feeling a bit sick in early pregnancy, and it's very time consuming, and it has 3 blood tests. So for the majority of women, a hemoglobin A1C will be the screening test, and a small number of those women, or women who've had gestational diabetes in the past, will have an early pregnancy GTT, and then if that's negative, go on to have a further GTT. The importance of diagnosing less women with gestational diabetes is that for some women, that diagnosis has some really negative implications and can be quite a shaming experience for some women. They carry a feeling that things that they have done or not done might have impacted on having that diagnosis and on their pregnancy outcomes. And taking that away and normalising a normal pregnancy experience for more women is really important when that's a safe and reasonable thing to do.
That's really good to hear, Alexis. It clearly shows that we have been listening to women who have had a diagnosis of diabetes in pregnancy and taking their feedback on board. Clinicians may have questions about the increased reliance on HbA1c rather than GTT. Can you explain this shift away from the glucose tolerance test?
Sure. So a oral glucose tolerance test is still the gold standard for diagnosing gestational diabetes, and that hasn't changed. But the hemoglobin A1c is being used primarily as a test for type 2 diabetes in early pregnancy. We know that our rates of type 2 diabetes are increasing in our communities as we change our ethnic mix and as women are becoming older in pregnancy and heavier in pregnancy. So all those things predispose to type 2. And it's very clear that diagnosing type 2 diabetes early and treating it early has benefits for women and babies. So the hemoglobin A1c test is primarily a test for type 2 diabetes, not for gestational diabetes. What it also has a use for is for diagnosing women who are more likely to have gestational diabetes. So women who have that borderline hemoglobin A1c, as opposed to a hemoglobin A1c that diagnoses type 2 diabetes, are then recommended to have an early pregnancy oral glucose tolerance test to diagnose gestational diabetes. In some sites have chosen to use a borderline hemoglobin A1c as a direct entry into a gestational diabetes pathway without doing the oral glucose tolerance test. And there are risks and benefits to doing that.
And of course, those will be decisions that I suppose individual health services will make based on their population and what they see regularly in their antenatal care.
Of course, and their workflow patterns and referral patterns and all of those things that we know are different across different sites. I think it is really important to say, though, that although hemoglobin A1c is a good test for type 2 diabetes, it is not a good test at 24 to 28 weeks for gestational diabetes. And we can see why it's very appealing both to clinicians and to women to have that single non-fasted blood test in later pregnancy, but it is not a reliable test in later pregnancy for gestational diabetes.
And that's a really important message that I think all of our listeners need to remember. Now, I'm sure you're hearing this, but I'm certainly hearing this from women who say, I was diabetic in my last pregnancy and my levels are exactly the same in this pregnancy when I've had the test, but now you're telling me I don't have diabetes. How do we deal with this?
So I think the really important thing is to be reassuring both women and clinicians that these are very evidence-based and safe guidelines. We've got a huge amount of data since the last time ADIPS made recommendations about gestational diabetes, looking at the risks of that mild hypoglycemia. And so we're basing those decisions on good quality randomised control trials that say that treating those women with the higher cutoffs, the newer cutoffs, is a safe thing to do. We do know that hypoglycemia in pregnancy is a continuum. There's no clear demarcation between normal and gestational diabetes. And so the aim was to choose a diagnostic criteria that maximised the benefits without creating those additional burdens.
And it's really good to be able to reassure women and actually tell them that this is based on evidence and research rather than us just plucking a number out of thin air.
Yes, absolutely.
Have you ever wondered how a RANZCOG clinical guideline is developed, or are you unsure of how to adapt the guideline into clinical practice at your workplace? Join RANZCOG's Translating Research into Practice workshop on Saturday, the 23rd of May, and experience a deep dive into the college's evidence-based guideline development process. You'll learn the practical skills of assessing evidence, translating it into practice, and integrating clinical guidelines within your own health service, and much, much more. You can attend in person at the college in Naarm, Melbourne, or online via Zoom. Register now at ranzcog.com/events and receive CPD hours for your participation. What do we do for women who either can't tolerate an OGTT or who decline one?
Yeah, so that's a really difficult space. So let's talk about women who find them difficult to tolerate first. And the common scenario is women who've had bariatric surgery. And depending on the kind of bariatric surgery, that can be quite a range of how a glucose tolerance test is tolerated. But the glucose load can be very difficult and very unpleasant for some women who've had bariatric surgery. Some women will have no troubles. There are a couple of options and none of them are perfect. So one of the options is to do just a fasting glucose. So that removes the burden of the bolus of glucose, makes it much more comfortable for those women. And we'll pick up many women with gestational diabetes by using just a fasting glucose, but we do miss the postprandial highs. And there may be some ethnicity-related differences in women who are more likely to have a high fasting or a high postprandial. And so we need to be careful that we're not discriminating against some groups by using only fasting glucose. Another option is to use home blood glucose monitoring. Now, again, a couple of troubles about that. One is that the strips and meters are not funded, and so there'll be out-of-pocket costs for those strips and meters, and they're variable depending on how the access is. The other problem is that we don't really know what the diagnostic criteria are. So if somebody's just doing home blood glucose monitoring, at what point do we say, well, you now have gestational diabetes or you don't, or you need to keep monitoring or you can stop? So it's not straightforward. The third option, also difficult, is continuous glucose monitoring. Now, again, there's financial implications. These are not funded and they have a significant out-of-pocket cost. And again, we don't really know what the normal ranges are for diagnosing gestational diabetes based on a CGM. So again, appealing in many ways because it doesn't involve finger pricking, but really not a recommended pathway at this stage. And again, hemoglobin A1C in late pregnancy is not a useful tool for diagnosing gestational diabetes.
So essentially, we are in a difficult space if we are not able to do the OGTT, and we would encourage most women, of course, if they can tolerate it, to have an OGTT.
Yes.
The updated guidelines no longer have ethnicity as a risk factor. Why was this decision made?
This, again, was one of those decisions with a lot of input and a lot of thought that went behind it. But the feeling largely has been that targeting screening based on ethnicity can lead to increases in inequality. And so that's been removed from the list of criteria. There are services that, depending on their own particular demographics in their area, particularly around their rates of type 2 diabetes, may just choose to screen everybody with a hemoglobin A1C early in pregnancy to make sure that they are detecting everybody with type 2 diabetes.
What about advice for clinicians who are trying to adopt these guidelines and potentially receiving questions from patients? Are there any places they can go for help?
Yes, so there's lots of really great information out there. I think what's really important is for clinicians to be confident in themselves and confident in reassuring women that these are safe, evidence-based guidelines. That's the starting point, but there is more information out there. So the ADIPS website has got some frequently asked questions both for clinicians and for consumers around the changes, and the Conversation has also published an article which provides a little bit more of a background that's freely accessible to anybody.
That's really good to hear. Alexis, what's next in research for GDM? What are the things that are on the horizon?
Yes, so it's a really active area of research, and because there are things that we don't know, there's lots and lots to investigate. So things will change again. I think in terms of diagnosis of gestational diabetes, one of the really exciting things that might come through is the use of a combination fasting blood glucose and hemoglobin A1C in early pregnancy to predict who is so unlikely to get gestational diabetes through their pregnancy that they never need to have a GTT. And that will be an enormous relief for lots of people. So hopefully we'll have some more information on that coming through soon. The other bit of data that's coming through is around CGM use. So for women no longer having to finger prick 4 times a day and instead be able to use CGM, once we know what those CGM levels mean, again, that'll be an enormous benefit. Funding implications, but an enormous clinical benefit. I think there's things about diet that we don't know, and it'll be great to be able to give more nuanced, more individualised, more evidence-backed information about dietary changes, because that makes a huge impact on a woman's life and her pregnancy and her family's life. And then I think the bigger picture of care we need to think about, making sure that all of our patients, not just of our patients with gestational diabetes, have really good access to the best evidence around diet, around exercise, around lifestyle factors, making for the healthiest pregnancy for them and for their baby. The other really exciting thing is that ADIPS is putting together a consensus document around management of gestational diabetes, which is something that the sector's certainly been asking for. All sorts of things around medication choices, treatment targets, all of the obstetric questions around the timing and mode of delivery. And we're hoping that after some very intensive stakeholder engagement, is going to be published later this year.
And that will complete this suite of guidelines, isn't it? We'll have something for diagnosis and something for management, which will be really useful for clinicians.
Yes.
Just a note in case people don't know what CGM is, it's continuous glucose monitoring. So to wrap up, Alexis, what are some of your key takeaways?
So I think it's really important we are all confident this is safe, evidence-based information and that it will reduce the number of women that we are looking after with gestational diabetes. It brings Australia into line with many similar countries around our diagnostic criteria rather than being a little bit of an outlier. These guidelines hopefully will make for a better screening and diagnostic experience for women, with many less women being required to do 2 glucose tolerance tests during their pregnancy, and that hopefully clinicians are already seeing that they've got more time to provide the best care for the women that need it.
You can read the ADIPS 2025 consensus recommendations for the screening, diagnosis and classification of gestational diabetes in the Medical Journal of Australia via the ADIPS website and linked in the show notes. If you enjoyed this episode, please rate, review and subscribe and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking O&G.